Hello, everybody. Good evening. How is everyone? So, I'm Dr. Aruj Afzal and one of the mentors of First Aid AMC. So, this is also one of your classes, the free session, and this will give you a little bit of idea that how we will be conducting our sessions. Okay, the purpose of today's session is to discuss some random questions to give you an idea of how the questions can come in the exam. All right. So this is random MCQs discussion, and like I said, we will be discussing random questions, and obviously the topics will be random, and that will help you to have an idea regarding various topics. And this is the key to this exam, that you have to start the solving the questions from the start of your preparation. Okay, and that will help you brainstorm and think. So these questions will be random. The sources that I will be using, and also which are recommended by the AMC as well for part one. First of all, the most important one is the AMC handbook. You should be doing this at least twice. All right. The references with the help of which we will be solving the questions. The first one is the RACGP. Okay, so this is like Royal Australian College of General Practitioners. Okay, it stands for this. And this website has many articles for various cases or diseases which can come in general practice, okay, which are usually seen in general practice. These articles, sometimes they can be the research articles, sometimes abstracts, but most of the times they are the guidelines which general practitioners usually follow. Okay, and this is recommended by Australian Medical Council as well. So, for example, if you have to read the guidelines, you just have to type. For example, you want to read peripheral arterial disease. You will just write on Google PAD RACGP, and the result will be you will get various topics, various articles, and try to read the recent most or the latest article for that topic. Okay, so for general cases, we will be following the RACGP. The RANSCOG and SA Health, these are for gynae and OBS cases. Okay, SA Health, South Australia Health Guidelines, they have very good articles for solving the questions for OBS. Okay, and RANSCOG, again, this is the Royal Australian College of OBS and Gynae. RCH, this is for PEDS, and it has very good articles for PEDS. So similarly, if you want to search a PEDS topic, just write that topic, and after that write RCH. So Google will give you the topics from this website. So RAN-CP, this is for the psychiatry. Although this has very, very extensive topics, you don't need those, but just for references, you can have a look on these on this website. For psychiatry, you have to know the DSM-5 criteria. This is just an overview, and by the time we will be solving questions and you will be also having theory classes, so you will get to know what is DSM-5 and how do we read that. You will get an idea, okay? For people who have given an attempt before or who have started their preparation, they will be knowing the DSM-5. But for new students who are just about to start their preparation, they will eventually get to know what is DSM-5. Okay. Australian therapeutic guidelines, again, they are the Australian guidelines regarding selecting the treatment of choice. Okay, we will also be referring to this time to time. Australian Immunization Handbook is for vaccinations, okay, or immunizations. So whenever we have to search for questions, we will be having this guideline. We'll be looking at this guideline. Similarly, there is a website called as STI Guidelines Australia. For STI, we will be having a look at this. Red Book, this is a book for screening of all the diseases, like screening criteria. This is by the RACGP. Okay, so in this book, you have all the screening guidelines. Like, for example, we have to see colorectal cancer. So we will be having a look at that red book for the guidelines. DermNet NZ, this is for the dermatology. This website is of New Zealand. It has a lot of good pictures for dermatology as well. As you know, in AMC exam, they definitely give you one or two questions containing pictures as well. So it is good approach if you see pictures from this website time to time. Okay, whenever you solve any dermatology question, make sure just to have a look of from this article of that topic. Similarly, for emergency cases or acute cases, there are two websites, Life in the Fast Lane and Emergency Care Institute. Both of these websites have very good articles for emergency cases. And last one is Australian Society of Infectious Diseases for perinatal infections. Okay, these all are very good references, and we will be taking references from these websites. And by the time, like when you will be used to solving the questions, you will get to know that how we read the articles. Obviously, it's not possible to read the whole articles, and but once you get a good grip of it, you will get to know how we read these articles. So this is a screenshot from AMC, the guidelines they have mentioned. So it, first of all, up to date is also very good, but obviously it requires subscription. Not everyone has it. Therapeutic guidelines, okay, state guidelines. For example, I told you about SA Health. Then RCH guidelines, the DSM-5 criteria, RAN-CP, okay, the Red Book, and then you have RSCGP, and then you have Australian Immunization Handbook and RANSCOG. So all of these guidelines are pretty much given by the AMC themselves. Okay. So AMC handbook, right now it is currently no new version of handbook has been given by AMC. So currently you have to follow the AMC handbook that is currently there. Obviously, for solving questions, you can have some other websites as well, but AMC handbook has its own importance. So let's start solving the questions. So first question is varicella in pregnancy exposure. Okay, we have just one option, check antibodies. So what do you think? What's the answer here? So now, whenever you are solving the questions, you can see that we don't have five options over here. So we can't guess. Sometimes they will be incomplete. But the purpose of solving these questions and that too randomly is to just give you an idea. And your purpose should be to read the topics. Okay. So this question, varicella in pregnancy. So now if this woman has been exposed, so further management would depend on her own status, right? If she has had chickenpox before in her life, or she has been immunized against varicella, so then no further action would be needed. But if her immunity status is uncertain or she is non-immune, then we would require antibodies and specifically IgG to see if she is immune to varicella or not. All right, because she is pregnant and obviously there is very fetal varicella syndrome as well. So this flowchart is from the ASID, which I mentioned, I had mentioned this article in the in my list of the references. So you can see here during pregnancy there is significant exposure to varicella zoster virus. So now we see if there is previous vaccination either or previous chickenpox history. If any of this is present, like we have the evidence of vaccination or mother had chickenpox previously, then no action is required. However, if there is no there is uncertain history, like we do not know, the mother does not remember whether she had a chickenpox or not, or she does not remember whether she had been vaccinated or not. In that case, we would have to check the antibodies. Okay, and that varicella IgG is very important to see the previous immunity. And then further management would be dependent upon the status of this antibody. If IgG is positive, it means that the mother is immune, right? So again, no action would be required. However, if IgG is negative, it means that there is no immunity present in the mother. Then we would have to give her immunization, passive immunization. That would depend upon the time of exposure. For example, they have written that if the exposure is less than 96 hours, then we can give passive immunization with varicella zoster immunoglobulin. However, if exposure is more than 96 hours, then we can give it within 10 days. However, the best thing would be to give it within 96 hours, but within 10 days it can be given. Okay. And if it is if the woman has developed symptoms or it has gotten very severe, then we can think of giving the acyclovir. Okay. And if more than 10 days, for example, have passed, then we can also consider giving oral acyclovir. All right. And then we would also monitor her for the development of symptoms. So this flowchart, you can see that any type of question comes, you will be able to solve it with the help of this. Okay. So in our case, it's just written that varicella in pregnancy exposure is there. So depending upon if the statement tells you if there was any previous history or previous history of vaccination, then no action. If there was uncertain history, then check IgG. If, for example, in your scenario, they have written IgG is negative, then what to do? Then we will, depending upon the time of exposure, we will give her zoster immunoglobulin or the passive immunization. Okay. Varicella vaccine, we don't give in pregnancy because it is live vaccine, right? So we give passive immunization. All right, so the link of this I have attached here. You can have a look at it afterwards. So right now, depending upon this statement, we can check the zoster antibodies. So next question is prostate screening. PSA is normal previously. Now it is 2. Physical exam is normal. What is next step? Again, we have one option which says nothing. So what do you think here? So for cancer guidelines, like I mentioned, we will be following the Red Book 10th edition, right? So regarding the PSA, there are a few things regarding the prostate cancer. One is that prostate cancer is extremely slow growing tumor. Okay. The data shows that 50% of males who are 50 years old, 50% of them have prostate cancer. 60% of 60-year-old men have prostate cancer. Similarly, 70 years old men, 70% of them. So 90% of men who are 90 years old, they have a chance of having prostate cancer. Okay, but the point is that it is an extremely slow growing tumor, and patients usually they can die with prostate cancer, but they usually do not die from prostate cancer. Okay, get my point? Like prostate cancer is not a very, you can say, aggressive cancer. It does not increase mortality to the extent that we normalize the screening. Okay, so prostate cancer screening, firstly, it is done with PSA, prostate specific antigen. Okay, and if there is no sound, guys, can you hear me? All right. Okay, so I am saying that PSA for prostate cancer screening, that is done by prostate specific antigen, okay, the blood test. So PSA is done in patients who themselves give an informed consent. Okay. For example, a patient comes to you just a person comes to you, he does not have any prostate cancer right now, and he says to you that my one of my relatives has a prostate cancer, and I'm very worried about it, and I want to get my screening done. So you, as a doctor, you will tell him all the risks and benefits of doing the PSA or doing the prostate cancer screening. Okay, because this cancer, like I said, it is very slow growing. So sometimes there is like a not sometimes, always there is a chance of over diagnosing this cancer. Okay, because it is slow growing, sometimes it does not need that much treatment, right? So we will tell the patient that this is like prostate cancer and this is a slow growing tumor. uh, you can have screening with PSA, but that is that risk versus benefit type of thing. You will tell him all the risks, all the benefits. Okay, benefits would be that you would be diagnosing the prostate cancer earlier, but risk would be that you would overdiagnose it and that would result in overtreatment. Okay, because radiotherapy and this surgery, they have their own risks as well, right? So even after telling this, the patient says, no, I'm giving the informed consent, I want to get it done. Then to those patients, we do the prostate cancer screening. Okay, otherwise in normal population, you do not recommend PSA screening. So now this patient, for example, or scenario says that this patient gave the informed consent and he has been having PSA regularly. So previously it was normal and now is it 2? Now it is 2 and physical exam is normal. So what do we do? 2 is also considered normal PSA. If it was more than 3, then we would have gone for further investigations. Okay. So all of this is written in Red Book. These are the screenshots from there. So you can see GPs should not order a PSA for men unless they provide informed consent. Okay, so I've explained this. What is the reason? The reason is written over here that there is a risk of overdiagnosis and may lead to treatment of men who may never become symptomatic in their lifetime. All right, so this is the reason that prostate cancer screening is not usually done in at a general community level. Okay, only to the patients who give informed consents or to the patients who become symptomatic, they will be having the screening. So we will be offering them risk versus benefits of the PSA testing. And now there is one more thing. You can see here average risk, moderate risk, and high risk. For all types of cancers that we will be discussing in our subsequent classes, you will always see that they define a risk level, okay, for any type of cancer. Over here in prostate cancer, you have an average risk. That is for a patient who does not have any family history of prostate cancer. Moderate risk is for someone who has a brother or multiple first degree relatives. Okay, first degree relatives are those first degree relatives include like father, brother, or son. Okay, if he's an uncle or a very far relative, that would be a second degree relative. So first degree relative, multiple, or a brother, then that would be moderate increase. Or high risk would be who has three or more affected first degree relatives. Okay, so now they say for the average person who does not have any family history, and who has been informed the risk and benefits, if they decide to undergo the testing, then we can offer PSA testing every 2 years. And further investigation, that is the total PSA, will be done if it is greater than 3. Okay, so most likely this is our case here. All right. So or patient, previously it was normal, but here it is 2, it is less than 3 right now. So although he's having PSA 2 yearly, but right now PSA was still normal or less than 3. So what we can say to him, we can say that PSA would be done every 2 yearly. Okay. And then this was for the average risk. If in your scenario it tells you that the patient is of moderate risk, for example, the brother also had a prostate cancer, so at that age, we can also give, so that we can offer every 2 years, the PSA testing from age 45 to 69. Okay, so here informed consent wouldn't be required, like risk versus benefit thing, you wouldn't be explaining to this patient. You can offer them PSA every 2 years. Okay, similarly for high risk, you are also offering PSA. Okay, so regarding this scenario, this all depends upon the complete statement. So, whatever I've explained, this tells that if the patient had agreed for informed consent and he had agreed for PSA, then we would be choosing the answer of PSA every 2 years. Okay, and since it is less than two, so just after 2 years. However, if though there was no informed consent and PSA had been done for other purposes, maybe like there was some suspicion of the cancer, then the option would be to do the nothing because PSA is 2. Okay. DRE is not used for screening purposes. Usually, it's just the PSA that is used for screening. DRE you can do if there are symptoms. Patient is having symptoms and we are suspecting some BPH or any prostate cancer, any prostate abnormality, then we will be doing the PSA, doing the DRE. All right. It's written over here. DRE is not recommended a routine addition to PSA testing in asymptomatic men. Okay. This is not done routinely for asymptomatic patients. So you can see here, any kind of question comes, Red Book is able to answer it. Okay, so it is important to read these guidelines. If it is high risk, then still 2 year PSA. It's written over here. The duration is not for 2 years for high risk. We will be doing testing the PSA, and if it is more than 3, then we will be doing a repeat PSA within 1 to 3 months. All right. So for high risk, it is different because they have not written every 2 years here. Okay. So I've attached the link of this here. So third question, again, it is a little bit incomplete, but the purpose of this is to show you the colon cancer guidelines. Okay. 53-year-old man, younger sister has colon cancer. So should he have a colonoscopy or FOBT? What should he have? So again, we have to follow the guidelines in order to solve this. So like prostate cancer, colon cancer also has been given some divisions, like some average risk, moderately increased risk, and high risk. Okay, so this might seem a little bit overwhelming right now, but you have to read these topics, you have to read these guidelines again and again, and until your exam, you will be good to go. Okay. So this is for asymptomatic patient, any patient who does not have any bowel symptoms, okay? And also they lie between the 45 to 74 years of age. Category 1, average or slightly increased risk. Category 2 is moderately increased risk. So one tip is you can remember just the middle category. Just try to remember what the middle one is saying. Anything more than that would be automatically high risk, and anything less than that would be average or slightly increased risk. Okay. So for moderately increased risk, you can see that there is one first degree relative who was diagnosed before the age of 60 years, or there was one first degree relative, and so now there is like and one or more second degree relatives with colorectal cancer diagnosed at any age. Okay, or there was two first degree relatives. So this is any of these three things. This is category 2. Okay, so if in your statement you have any of these things, you can confidently say that this patient is at moderately increased risk of developing colorectal cancer. Okay, so what do the guidelines say for moderately increased risk? You will be doing colonoscopy every 5 years. So this patient will have colonoscopy every 5 years, starting at 10 years younger than the earliest age of CRC in first degree relative, or 50 years, whichever is earlier. Let me explain this to you. So, this patient has a younger sister who was diagnosed with colon cancer. This patient is 53 years old and he's asymptomatic. Okay, so if he's 53 years old, definitely his younger sister would be less than 53, right? So she was diagnosed at less than 60 years. So this makes this patient to be at moderately increased risk, right? Because first degree relative is has been diagnosed with colon cancer at less than 60 years of age. So he's at moderately increased risk. And what are we doing? We are doing colonoscopy at 10 years younger than the age of the relative. For example, if this patient, this younger sister, for example, she's 2 years younger, let's assume she's 51 years old. So colonoscopy for this patient has to be done either 10 years before, all right, 10 years younger than the earliest age. So if, for example, if the sister is 51 years old, so this patient screening should be started at 41 years old or at 50 years, whichever is earlier. So from 50 and 41 years, 40 comes first, right? So this patient ideally should have had screening from 41 years, but obviously he's 53 years old now. So what we can do is we can offer him a colonoscopy now, and after that he will be having colonoscopy every 5 years. Okay, so the complete option or the best answer would be do a colonoscopy now and then after repeat after every 5 years. Okay, because this patient is at increased risk of developing colorectal cancer. Why not FOBT? FOBT is for this average risk. The category 1 patients, they undergo FOBT every 2 years. Okay, the average or slightly increased risk. So they have who are these people who lie under the category 1 who have no family history. So there is no family member who have ever developed a colorectal cancer. Okay, or if they have only one first degree relative above the age of 60, either at or greater than 60. If in this scenario, this sister was older, for example, this sister was 61 years old, then this patient would lie under category 1 and then he would be having FOBT regularly every 2 years. Okay, so this is because of the age that makes this patient at moderate increased risk. And for moderate risk and high risk, we do not do FOBT, we do colonoscopy. Okay, it is also important that you follow the latest guidelines for colorectal cancer. And for those guidelines, you can refer to Red Book that is very much updated. Okay. So for this category 1, we are doing FOBT 2 yearly, and for category 2, we are doing colonoscopy every 5 years from the age 50 or 10 years younger than the first degree relative age, whichever is earlier, up till the age of 74 years. Clear, guys? And then category 3, you also do colonoscopy, but that would be also every 5 years, but that would, the age is 40 years instead of 50. Okay. This is written for higher risk, every 5 years starting at 10 years younger or at age 40, whichever is earlier. So any type of question comes, we will be able to solve it. So for this patient, moderately increased risk, we can do colonoscopy now and then after every 5 years. All right. This is the link for Red Book. All right. Again, another question. Gastrointestinal bleeding, hemoglobin declined, and normal colonoscopy. Should we do a CTA, CT angio, or capsule endoscopy? So there are three terms that you need to know. This is the case. Let me just explain you. So right now you can see that there is a GI bleed. most likely it is looking like this is some very visible bleeding, for example, any hematomasis or melena or hematochezia. And there is hemoglobin is declining, means there is some active bleed. But patient underwent colonoscopy, it turned out to be normal. Still the patient is bleeding. What should we do? CT angio or capsule endoscopy? So let me just explain you three terminologies that are used for GI bleeding. Okay. Number one is overt bleeding. Okay, overt, OVERT. Overt means something which is very much visible. So overt bleeding includes hematomasis, that is blood in vomiting, or hematochezia, the blood in stools, or melena, the black tarry stools. Okay, that show the evidence that bleeding, GI is like there is bleeding somewhere in the whole GI tract. There is one term which is called as occult bleeding. Occult means something which is hidden. Okay, so you will not be able to see that bleed with the naked eye. All right, so there would be like microscopic bleeding, but that would be causing hemoglobin decline because it would be very constant, and it would be causing sometimes iron deficiency anemia as well. That is called as occult bleeding. And for that, we do FOBT, right? Fecal occult blood testing, because it tests the blood which is not seen with the naked eye, but there is like a bleeding in the GI tract. The third term is obscure bleeding. Obscure word is given to something for which we did investigations, but no identifiable source was found for that bleeding. That is called as obscure bleeding. So this obscure bleeding, it can be overt, in which there is visible bleeding, or it can be occult as well, in which the bleeding is hidden. We cannot see with naked eye. So anything for which the source cannot be found, that is obscure bleeding. So now you can see here the colonoscopy is normal. So this is the case of obscure bleeding. Okay, so for obscure bleedings, there are some guidelines. So now you have a clear concept of these three words. Let's follow the guidelines. Okay, so first of all, you are suspecting acute overt GI bleed. Overt means visible. So, for example, the patient presented with hematomasis, right? We will resuscitate the patient and then do upper endoscopy or colonoscopy, depending upon the case. If the source is found, no problem, we are going to treat it. If the source is not found, okay, so and then we will look at the hemodynamic stability of the patient, whether the patient is stable or unstable. Okay, vitally he is stable or unstable. If he is stable, or the bleeding is very low, that means he's stable, we are going to manage it as obscure bleeding. I will be talking about it in a while. If the patient is unstable, hemodynamically unstable, his vital signs are dropping, there is massive bleed. So if he's unstable, you are going to do catheter angio. If there is a massive bleed, then you can do CT angio. Okay, so CT angio is for someone who is having a massive overt GI bleed. And if the patient is unstable, we can go with catheter angio. If still no source found, then radionuclide, technetium-99 scan can be done, or ultimately we would have to do surgery in order to explore from where it is bleeding. Okay. Similarly, this flowchart is for the occult bleeding. Occult means, like I mentioned, it is hidden bleed. It is not seen with naked eye, but FOBT is coming positive. Okay, so we evaluated and then we saw that FOBT is positive, but patient does not have iron deficiency anemia. We will be doing colonoscopy. If source is found, we are going to treat. If no source found, no further evaluation unless anemia develops. So if there is no iron deficiency anemia and colonoscopy is normal, or it did not find anything but FOBT was positive, we will just, like you can say that until anemia develops, we will not be going with further investigations. However, if the patient has developed iron deficiency anemia, so we will be doing both upper endoscopy, upper GI endoscopy and colonoscopy. Source is found, specific treatment. If it is not found, then we will manage it as obscure bleeding. Okay, so in both cases, in case of overt, in case of occult, if the source is not found and patient is stable, or if the source is not found and there was iron deficiency anemia, we were managing it as obscure bleeding. So now let me show you the guidelines of obscure bleeding. So now you can see, you have seen that obscure can be either overt or occult, right? So obscure bleeding, first thing is to consider repeat upper endoscopy and colonoscopy. So this answers your question somewhat, that if you have the option of repeating the colonoscopy or endoscopy, go with that. However, if you don't have that option or if they have already repeated that, then we are going with capsule endoscopy. Okay, so for obscure bleeding, for which the source has not been found, even after repeating the endoscopy and colonoscopy, we are going with capsule endoscopy. Because most likely, when you can't find the source by upper GI endoscopy, you know that upper GI endoscopy usually sees up till ligament of triads, right? The duodenojejunal flexure. It is usually the things are visible up till that. And colonoscopy, it is used to visualize the lower GI tract. So sometimes there can be bleeding in the small intestine, for which capsule endoscopy is the best, and it can take a very like good quality HD pictures of the small intestine, and is very beneficial, and usually it finds the source. So if there is obscure bleeding, even after repeating you could not find any source, then you can go for with a capsule endoscopy. So if the source is found, we can go for specific treatment. If the source is not found, then there are some other imaging procedures, like there is deep enteroscopy or double balloon. If still no source found, then we can go with further investigations, or maybe laparoscopy would need to be done if there is severe iron deficiency anemia, right? So this is all the guidelines that you can follow for GI bleeding. So in our case, actually we don't know whether it is overt or occult, but still depending, it is normal colonoscopy, so it means that there is no cause had been identified with that. So here we can go for capsule endoscopy, considering the patient is hemodynamically stable, all right, and it is obscure bleeding. Okay, so you have to remember these flow charts, and they're very easy. The tip is to go through them again and again. Okay, this is a similar one, like I've mentioned, and they've mentioned the common causes of obscure bleeding, of why sometimes cause cannot be found, because there can be something which is bleeding in the small intestine. Okay, small bowel tumors, any vascular anomalies, any diverticula, or sometimes celiac disease in the small intestine. Okay, so, emphasis in diagnosing the obscure GI bleeding is the investigation of the small bowel. And for this purpose, the capsule endoscopy is the best one. Okay. So, assuming this is ongoing or recurrent bleed, colonoscopy is normal and no upper GI source has been found, then we have to consider repeat endoscopy and colonoscopy. And after that, if still no cause is found, then we can go with a capsule endoscopy. If patient is hemodynamically unstable, then catheter angio, or if there is massive bleed but patient is hemodynamically stable, then CT angio. Okay, this flow chart is also given in MEDEX as well, if anyone of you has solved those MCQs. So these are also given in MEDEX, the obscure bleed, GI bleed. So I have attached the links to these as well. Let's move on to the next question. So there's a 7-year-old child. He started a new school, doesn't like going to school. There's decreased interest. He likes to arrange toys neatly. Good eye contact while talking, introduces his toys to you. So they're asking for diagnosis: autism spectrum disorder, ADHD, Tourette syndrome, or oppositional defiant disorder. So, for diagnosing the psychiatric diseases, like I said, we need to follow the DSM-5 criterias. What I'm going to show you is the DSM-5 criterias of autism spectrum and ADHD. It seems very long, but trust me, in DSM-5, I think this is the longest DSM-5 criteria. Okay, so don't worry. But the point is that for diagnosing psychiatric diseases, they need to follow whole DSM-5 criteria. Otherwise, you cannot diagnose. Okay. So for autism spectrum disorder, you can see that there are two types of things. One is problem in the social communication or social interaction, and one is restrictive or repetitive behaviors. Okay, in at least two of the following. So they have given a list, and at least two of them should be there. One is repetitive motor movements, use of objects or speech, lining up toys, flipping objects, echolalia, idiosyncratic phrases. So we have lining up toys here. Okay, this child likes to keep his toys in a straight line. Okay, other things are adherence to the routines, ritualized patterns of verbal or non-verbal behavior, that is extreme distress at small changes, difficulties with transitions, rigid thinking patterns. So in our statement, although it isn't not mentioned directly, but there is a thing that he started a new school. So there is a change in his routine, right? The routine that he was fixed to it, there is a slight change in it. He has been going to a new school now. So two of these criteria is already being fulfilled. Then there are some highly restricted fixated interests. Okay, example, they have given strong attachment with unusual objects. Okay, or there is hyper or hyporeactivity to sensory input. Okay, for example, apparent indifference to pain or temperature, adverse response to specific sounds or textures. So you might have seen an autism patient, if you have seen that in real life, you might see that sometimes they become very sensory overstimulated and they can react very strangely. So this is like comes in the behavior patterns. Regarding the social one, there is deficits in social emotional reciprocity. Okay, so they have abnormal social approach, failure of normal back and forth conversation. Okay, if even if their communication is fine, they're able to speak in full sentences, but still they are unable to connect emotionally. Okay, they are unable to share their interest, emotions, or affect means mood. Okay, and also deficits in non-verbal communications. You know that empathy or mood, one is like verbal, that is patients like you can say that one is that you say with your mouth, like with the sentences, and one is non-verbal communication that you show with your facial expressions or body movements, right? That is also important for interaction. So they can have problem in that as well. Poor eye contact, poor body language or deficits. Okay, and they can also have some difficulty in maintaining and understanding relationships. All right, so all of this in is in social behaviors. Okay, so there are two things. One is repetitive behavior patterns. One is social problem. And then DSM-5 criteria says that symptoms must be present in the early developmental period, and they cause significant impairment in social, occupational, other areas of functioning. And then they are not better explained by intellectual disability, for example, global developmental delay. So they are saying that the child, they are not explained by any intellectual disability. For example, if there is like a cerebral palsy child, maybe a very mild cerebral palsy. So you cannot say that the child has autism if you have not ruled out that. Okay. So what I mean to say is, for diagnosing a child with autism spectrum disorder, you need to have this whole criteria fulfilled. Okay. So restrictive patterns, you have to have at least two. And this social problem, you have to have at least one. Okay. And like this name indicates, autism spectrum disorder. Okay, so this is a whole spectrum. You can see, you might see in your real life as well that sometimes You can have a very severe, you can have a patient who has very severe ASD. He will not have any communication, no eye contact, and a lot of these behavioral problems as well will be there. But sometimes you can see a very normal child, it will look very normal to you, but he will still be diagnosed with ASD. He will be fulfilling this criteria, but it would be very mild. Okay, so spectrum means anything which is ranging from very mild to very severe. All right. So, although in order to diagnose with ASD, you need to have some more statements as well. But from these four options, ASD seems the best one because ADHD, now let's see the ADHD criteria. This is the DSM criteria of ADHD. Again, very long, but you need to understand that there is, like, as the name indicates, attention deficit hyperactivity disorder. So there is problem in the attention and there is problem with the hyperactivity. Okay, so they have given many things from which you need to have six or more of inattention and again six or more of hyperactivity. As we will be discussing the MCQs, you will be seeing that we will be discussing ADHD, autism a lot. So don't worry about all of these information. You will be having a regular and you can say recurrent revision of this. So by the time your exams come, you will be able to understand it. Okay. Right now, just understand that attention deficit hyperactivity disorder, there is problem in the attention as well and problem with the hyperactive as well. Okay, the child must be less than 12 years, and then there is the ADHD must be present in two settings, two or more settings. Okay, that is home, school, work, two or more settings, the problem must be there. And then they are not better explained by any other disorder. Again, the DSM-5 criteria. So this patient does not have any evidence of any hyperactivity or any inattentiveness. Rather, this thing is going more with the ASD. Similarly, third option, Tourette syndrome. Tourette syndrome, you know that this also has a DSM-5 criteria, but to summarize it, in Tourette syndrome, there are multiple motor tics and one or more vocal tics. This patient does not tell any evidence of any motor or vocal tics. There are no motor or vocal tics. Okay, so Tourette syndrome is very less likely here. Similarly, oppositional defiant disorder. This is also a psychiatric disorder in which the child usually is very, you can say, he defies or he has argumentative behavior toward his peers. Okay, like his seniors, his parents, his teachers, he will have a argumentative behavior with those. So it does not need to be related any to this, like arranging toys neatly, regarding the eye contact. They have everything fine. Okay. So oppositional defiant disorder is also less likely. These two things are left. I have explained ADHD, why is it less likely here. So from these four options, autism spectrum disorder is more likely. The point here you have to grab from this question is you should know the DSM-5 criteria of autism spectrum disorder. If in your exam, looking at the whole statement, if you have some suspicion that this is ASD, go with that. But there is common misconception that if the eye contact is normal, it is not ASD. I would say that is not correct because it's the name indicates it's like a whole spectrum. Okay, so it just also everything is written over here. This is again from the DSM-5 and it shows the three levels of a autism spectrum disorder, ASD, in which level 1 is requiring just support. It is very mild, but level 3 requires very substantial support. It is very severe. You don't need to learn all of this just for making concepts that ASD can be very mild as well. Okay. So this child does not meet full criteria for any of the options, but like he may have any normal adjustment to new school, possibly anxious or perfectionist personality because of the sentence that he tries to keep his toys in the straight line. Okay, maybe he likes organization. It can be early anxiety or OCD. Maybe we have such options in our exam. if there are no options, or you can very confidently go with autism spectrum disorder. Okay, but if you know the DSM-5 criteria, you would have no problem in diagnosing in the exam. Okay. So next question is, man with lack of interest in normal life, insomnia, visual hallucinations, and voice in his head. He's saying my mother died last month, but it is not the case. His mother died a year ago. So what's the diagnosis? Personality disorder, depression with unresolved grief, major depression with psychosis, or schizophrenia. So the key feature over here from this case is this lack of interest, okay, also called as anhedonia. And in order to diagnose depression or MDD, one symptom must be either low mood or lack of interest. One of them must be this in order to diagnose MDD. Okay? Lack of interest or anhedonia is a very important symptom of depression. You cannot just ignore it. Secondly, insomnia is there. Thirdly, okay, yes, there are visual hallucinations, okay, and delusions that he thinks that his mother died last month, but actually his mother died a year ago. So this is like a false belief and this is like a delusion. But important thing here is this delusion is mood congruent delusion. Okay, so meaning it is not bizarre. In schizophrenia, you have bizarre delusions. You have delusions of grandiosity. For example, the patient says that I have some superpowers. The patient has delusions of reference or control. Like patient thinks somebody is trying to harm him. He has very superstitious, or you can say like very unique delusions. Okay, bizarre delusions which do not make sense in normal life. But if it is any delusion related to depression, in like over here, major depression with psychosis, usually the delusions are related to that factor or important factor in his life. So over here you can see that his delusion is related to the mother's death. Okay, so he thinks that his mother died last month, but actually she died a year ago. So this is a mood congruent delusion, and it is going more with more major depression with psychosis rather than schizophrenia. Okay, and also just because the patient has hallucinations, you cannot say that this is like schizophrenia. Hallucinations and delusions can come in any psychotic episode. It's not necessarily always schizophrenia. Okay, depression with unresolved grief. This does not have hallucinations. Okay, there is no psychotic episode over here in depression with unresolved grief. And like this would present patient having very low mood, all the MDD symptoms, and with complicated grief, sorry. Okay, if the grief has been very prolonged, that is called as complicated grief. So it can be that, but here we have hallucinations, so we have ruled the B option out. Secondly, the personality disorder. Again, the personality disorder, they don't usually present like this. They don't have hallucinations or delusions. Okay, so personality disorder. Also, it is a very vague term. What kind of personality disorder? There are a lot of personality disorders. So this is also less likely. We are left with two options. I've explained the difference between the two. Schizophrenia is also less likely. First of all, at least 6 months, the criteria, DSM-5 criteria of schizophrenia says that at least 6 months the symptoms should be there. Okay, and the delusions, they are bizarre. There are auditory hallucinations, and there is disorganized speech as well, and there are different factors which make schizophrenia. But over here, if we see like anhedonia, insomnia, it is going more with major depression with psychosis. Okay, although we do want a full MDD criteria, you might know it SIGE caps, right? So we need major depression needs to have whole 5 out of 9 SIGE caps criteria. But from these four options, this one is the best that is fitting this statement here. Okay. Again, this is the DSM-5 criteria of schizophrenia and schizoaffective disorder. So, schizoaffective disorder is another term, although we don't have that in options, but it is somewhat related. Schizo, some features of schizophrenia, and affective. Affect means something related to mood. Okay, so anything like the disorder which is having schizophrenia features as well, and affective or mood features as well. Now, this mood can either be depression or bipolar, anything. Okay, so this is called as schizoaffective disorder, combination of both. How is it different from this? Major depression with psychosis. There is, I have attached these references from, again, from the DSM-5 criteria PDF. Okay, so you can see here the distinction between schizophrenia and major depressive or bipolar disorder with psychotic features depends upon the relationship between mood disturbance and psychosis and severity. If delusions or hallucinations occur exclusively during a major depressive or manic episode, then this is depressive or bipolar disorder with psychotic features. Okay, in short, or to summarize, if you have hallucinations or delusions apart from the mood symptoms, that is insomnia and hedonia. For example, if the patient had insomnia and hedonia for 2 weeks, but that has resolved and now he's having some hallucinations. Okay, then that can be schizophrenia. That is hallucinations, delusions occurring apart from the mood symptoms. They occur exclusively. All right. But in schizophrenia, but in the major depressive or bipolar with psychotic, usually you have a mixture of these two things. Okay, similarly, schizoaffective disorder as well. This requires the active phase symptoms, that is, the currently the patient is having the hallucinations, delusions, the mood symptoms be present for a majority of total duration. Okay, so it means that the time during which your hallucinations and delusions last, for example, a patient of schizoaffective disorder, if his hallucinations last for 2 weeks, his depressive symptoms or manic symptoms will also be lasting for the same 2 weeks. That means whenever he's having the symptoms of schizophrenia, he's also having symptoms of mood disorder. They are occurring together. That is schizoaffective disorder. Okay. But the depressive with psychotic features, the patient is having MDD, but sometimes he has this psychotic element, sometimes the hallucinations or delusions. Okay. But in schizophrenia, you only have hallucinations, delusions, disorganized speech. Anhedonia and insomnia are more going with major depression. Okay. Yes, doctor. Like I said, this is like the overview in the recalls. We cannot discuss the whole topic, but we will be undergoing regular reviews, also doing the theory as well. Dr. Shan will teach the theory. So you will have a better idea of all these disorders. Okay. So for the purpose of this MCQ right now, you need to know the difference between schizophrenia and major depression with psychosis. Okay, that I have told. This statement is going more with this C option here, major depression with psychosis. Okay, don't worry, we will be going under, because these are very common topics for AMC: schizophrenia, depression, schizoaffective disorder. So it, like, you will be having to read this DSM-5 criteria again and again. Okay, that is the important thing. Like, that is why we prefer that you do the MCQs randomly, so that time to time you can read these criterias again and again. Okay, because you can see that these are very long criterias, and if you just read it once and then you will just forget it. Okay, so it is important that you read it again and again. So we will be going all like reading all of this DSM criteria in detail in future. This is the DSM-5 criteria of MDD. You know the whole SIGE-CAPS criteria. In short, delusions in schizophrenia are bizarre and mood incongruent. In the complete STEM, look for the whole MDD criteria. or whole schizophrenia criteria. Okay, you can answer major depression with psychosis here. Next question is schizophrenia patient. He has been treated with haloperidol, now resistant to treatment. Next step, clozapine or olanzapine? So this patient has tried first generation antipsychotic. He can try second generation right now, so we can give him olanzapine. If, however, after even two or three second generation antipsychotics, if still his schizophrenia does not get better, then the last resort is clozapine. Okay, because although clozapine is a second generation antipsychotic, but it has a lot of side effects, serious side effects. One of them is the agranulocytosis, in which you have decreased neutrophil counts, right? So that disposes patient to a lot of infections and like life-threatening infections. So clozapine is always the last resort. When nothing else is working, we will give clozapine. So right now, this patient can try olanzapine because he has not tried second generation antipsychotics yet. Yes. Next question, liver mass 3 centimeter in size. Patient is using OCPs. Diagnosis, liver adenoma, hydatid cyst, or hematoma. Yes, so with oral contraceptive pills, it is a very common side effect or complication, you can say, that the patients develop a hepatic adenoma. Okay. And hydatid cyst, Echinococcus granulosus is the infective agent. And hematoma, it's like just a collection of blood. But if the patient is going with patient is having OCPs, liver adenoma or hepatic adenoma is more likely. All right, it is 3 centimeter in size. What is the treatment of this hepatic adenoma that is caused by the OCP? So they can also ask you the treatment as well, right? So first of all, important thing would be to stop the OCP, right? And give her any alternate contraceptive measure. And it is 3 centimeter in size, so just follow up would be required. Follow up imaging or ultrasound or anything would be required just to see if this adenoma is regressing or decreasing or shrinking or not. Okay, if it was more than 5 centimeter, then with along with stopping the OCPs, if it is more than 5 centimeter, usually it is resected. Okay, surgery is done. Uh, and in case of males, the cause can be anabolic steroids. Okay, people who use anabolic steroids in while doing gym or anything, the males, they can develop hepatic adenomas as well. So for males, any size, you do the surgery. Why? Because there is a lot of potential for this adenoma to be to become malignant, to undergo malignant hemorrhagic changes. Okay, so that is why in males who are using anabolic steroids and they have developed this adenoma, any size, whether 1 centimeter, whether 10 centimeter, any size, you have to refer for surgery. You have to remove that adenoma. However, in case of females who are taking OCPs and they have developed this adenoma, the cutoff is 5 centimeter. If it is more than 5, then refer for surgery. Otherwise, if it is less than 5, just keep on monitoring with follow up with ultrasounds. Okay, and remove this offending agent. So it is related with the OCPs, hepatic adenoma. So let's take a 5 minutes break here and then we will continue with the rest of the questions, okay? All right, hello everyone. Let's continue our discussion. Okay, so next question is a man who is irritated. He said people are in danger, they will be killed. Management, call the police, call security, or provide him tea to calm him down. Yes, so this patient, most probably he's having some psychotic episode. He's having some delusions. Okay, so the important thing here is to ensure the safety. So we will be calling the hospital security. Okay, if things get worsen or the patient does not get controlled after all our measures, then we can call the police. Otherwise, right now, calling security is sufficient. And the third option, providing him tea to calm him down, is not a right approach. And maybe it will unintentionally escalate the situation. Okay, so you always need to have a backup. Like you have to call the security when you need to approach to the psychiatric patients who are having some emergency. Okay, so this is from the Australian therapeutic guidelines, the steps in the management of acute behavioral disturbance. So first of all is recognize that the patient is having some psychotic episode, and they are saying that attend them in the first instance. Ensure safety of self, staff, and others. Okay, so we will be summoning support, for example, security staff. And then there is like verbal de escalation, including the offer of medication that we have to give them orally. Show of force means that you need to go together. Okay, so all the security people and your colleagues, when you like four or five people go together in front of the patient, sometimes they can get they calm down. Okay, if you show a force, this means just this. Then physical restraint by a trained team. You know that physical restraint by normal people, that is not usually recommended. It is discouraged, but a trained team which is specifically trained for physically restraining a patient, you can call them. Okay, this team usually has six people. Four people are holding the arms and legs from the joints, okay, from the wrist joint and the ankle joint. One is holding the head, and the sixth one is injecting the medication or giving the medication. Okay, so then the chemical restraint. All right, so this is like the sequence with which you have to go. So we will be calling the security, okay, for the safety. Next question is 39 years old man found to have been unconscious and he was treated in the ER, and he regained consciousness and he shouted and said that he will give lessons to his wife. His wife has applied case against him for domestic violence and they have two children. So what to do now? Inform police, admit under medical tribunal, inform child protection services. So this patient has, there is a history of domestic violence, okay? And he has made a threatening statement that he will give lessons to his wife. So this implies that there is some intent of harm that he may give to his wife. And thirdly, they have two children, okay? So what you need to do, the wife has already applied case against him for domestic violence. Okay, but the important thing here is that the children are at risk of harm. Although it is not mentioned in this statement, but we would go with inform child protection services. Why? Because this wife has already made a case against him. If it was like a first episode, we would say, then we would recommend the wife that you can inform the police. Okay, we do not usually inform the police on behalf of the wife in case of domestic violence on behalf of the partner. We usually recommend them. We give them the numbers of support groups We give them the all the important contact information, and we say that whenever you feel unsafe or you feel like there is some threat in your home, you have to call this number. You can go there. Okay. Currently, this patient does not have any access to weapons. We do not see that. Okay, just says, he did not say that I will kill my wife or something. He just said I will give lessons to wife. Wife has already applied case against him. Okay, so the process is, you can say it's under like progress. So right now the important thing here is there are two children. We need to inform the child protection services. This is from the New South Wales guidelines. What must be reported? And you can see here the children or young person is living in a household where there have been incidents of domestic violence, and consequently the child or young person is at risk of serious physical or psychological harm. Okay, so under the New South Wales guidelines, if there is a domestic violence in house and children are at risk of psychological or physical harm, you need to report to child protection services. Okay. In some states of Australia, it is mandatory reporting. In some states like Victoria, it is just voluntary reporting that you can report. Okay. But important thing here is the uh, wife has already applied case. If this sentence was not mentioned, okay, if it was like a first episode, we may advise her to inform the police. Okay, but right now everything is under progress, but we need to do something about these children because this man, he's just not making things calm. He's just saying that he will give lessons to his wife. The children are under some psychological abuse. Okay, so we need to inform the child protection services. Child protection services will make sure that the home is a safe space for these children. Okay, because if you don't, if like at some place the children are in some dangerous area or they have some harm or any risk of harm, and if you don't inform the child protection services, you can get a penalty. Okay, you can get your license cancelled. Many things can happen, so it is recommended to inform child protection services wherever there is a risk of harm to the children. And this is written what must be reported. Must. Okay, so child who are living in the household where there is domestic violence, you must report to child protection services. Okay. um Regarding the B option, wait a minute. Regarding the B option, you can see admit under mental health tribunal. Okay, so this is Mental Health Act, and there is a specific criteria under which you can admit the patient. Uh, when there is risk of harm to the society or surroundings or to the patient himself, and the patient is having some psychological problem, and there is no less restrictive way to control the patient or to treat the patient, and the patient is not accepting a voluntary admission to the hospital. That is, he's saying that no, I'm fine, I don't want to be admitted, I'll just go home, but he's a threat to himself, to his surroundings, and there is no less restrictive way to treat him. Okay, so in that case you can admit under the Mental Health Tribunal or Mental Health Act. So this is not the case right now. Here nothing like such things are mentioned, so this is not the most immediate thing that we will do. Most immediate thing is to inform the child protection services if the mother has already applied the case against the husband. All right. How about the condition of history of unconscious patient? Do we need to further investigate by admitting the patient? Yes, this statement says that he has been treated in the ER. So most likely, maybe investigations have been done. So this MCQ is regarding what to do next for like it's the ethics question. So maybe the organic findings or anything or any investigations they have been done already, because this is written he's being treated in the ER. Okay, so the rest things are being taken care of. So regarding the patient, always be aware of patient's autonomy. Choice to report domestic and family partner violence rests with patient. Okay. So we can inform this mother, this wife, that you can report the police. All right. Next question is left hemicolectomy for colon cancer. Pathology shows malignancy. What is the most effective treatment to reduce the recurrence? Total abdominal radiotherapy, intraperitoneal chemotherapy, or total colectomy? Always try to follow the guidelines, doctors. There are only three options here. Okay. There can be two more options. Important point is that you should know that if there is like a colon cancer and the patient has had left hemicolectomy. Okay, so the adjuvant chemotherapy is usually given, and if you might remember the name, it's Folfox regimen, right? The 5-fluorouracil, the oxaliplatin. That is given systemically, that is, it is given intravenously. Okay, it is not intraperitoneal chemotherapy. Intraperitoneal chemotherapy would be done when there is like any peritoneal metastasis or anything like that. Total abdominal radiotherapy, this is also not recommended because the colon is like a mobile thing, okay? And if you give radiotherapy to the whole gut, it would be rather dangerous. It would be harmful and it would cause infection or inflammation there. Total colectomy, you don't do it unless required, unless the whole colon is infected. There is some family history of Lynch syndrome, polyposis, colorectal polyposis. In that case, you do the total colectomy because of risk of the entire colon being affected. Okay, right now, this patient does not need this one either. The best thing would be to look for systemic adjuvant chemotherapy, okay, because this is what we give for the um, colon cancer, which is stage 3 or above, okay, the adjuvant chemo. So this is Folfox, but this Xelox chemotherapy is there as well. But the thing is that you have 5-fluorouracil and you have oxaliplatin in it, okay. So I have explained all three options. Okay. So if you have the option of systemic adjuvant chemotherapy, that would be the best one because this is what is written in the guidelines, the Folfox regimen. Next question, very important. It comes almost every month. 80-year-old asymptomatic routine check. Leukocytes detected and showed resistant and sensitive to medication. Asked for treatment. Nothing to do or trimethoprim, sulfamethoxazole. So this is asymptomatic bacteriuria. The patient does not have any symptoms, but there are leukocytes detected in the urine specimen. Okay, so you don't treat asymptomatic bacteriuria unless the patient is pregnant. So if there is like a pregnant female, you treat asymptomatic bacteriuria, okay, because of risk of neonatal sepsis, okay. And if the other condition or the other indication is when any patient is going to undergo any urological procedure, okay. For example, the patient is going to undergo TURP, transurethral resection of prostate, or the patient is going to undergo, you can say, PCNL for any renal stone. Okay. So in those cases, any urological procedure, you treat the asymptomatic bacteriuria. Why? Because, for example, in case of TURP, you are going to treat the prostate cancer, prostate BPH. Okay, so when you are going to touch this mucosa or have some instruments rubbed against this mucosa, you will expose the blood streams with this urine. Okay, there might be a chance that this might happen. So if there is bacteria in the urine, there will be a chance that you introduce that bacteria into the bloodstream, and hence the bacteremia will develop, right? We don't want bacteremia, right? That is why before undergoing any urological procedure in which there is some suspicion of urine coming in contact with the bloodstream, then we treat this asymptomatic bacteriuria. Okay. And the other condition I've told you, the pregnant females. Everything else you don't treat unless it is symptomatic. If symptoms develop like urgency, burning micturition, or all those urinary UTI symptoms, then of course you have to treat it. If it is asymptomatic, you are only going to treat it in case of pregnant women or any urological procedure where mucosal bleeding is expected. Okay. Here you are treatment is recommended, and here treatment is not recommended. So this is like the elderly people, whether they are institutionalized, that is they are living in some um, uh, 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 aged care facility, or they are in the community. All right. Any women with diabetes, still you don't need to treat because they will have recurrent infections. As long as they are not symptomatic, you don't need to treat because they will have it again and again, and you will just cause harm by giving antibiotics again and again. Rather, the resistance will develop. Okay, so you don't need to treat it unless symptomatic. Again, premenopausal non-pregnant women and patients with spinal cord injury, all of these, they usually have some bacteriuria, but as long as it's asymptomatic, you don't need to treat it because we don't want antibiotic resistance. Okay. So here, this is like an 80-year-old elderly, not undergoing any urological procedure, so nothing to do. So we are not going to treat it. ECG irregular heartbeat didn't look like atrial fibrillation. How to assess cardiovascular risk? Charles score or CV assessment? So this is very important to know that which scoring you will do for what. Okay. If the ECG does not look like atrial fibrillation, then we will do the cardiovascular risk assessment, the normal one, which is called as Australian CVD risk calculator. Okay, so this is again from the Red Book. When do you do Charles score? Charles score is done when there is atrial fibrillation in a patient and there is risk of having some stroke. Okay, and you need to give that patient some anticoagulant in order to prevent that stroke. So Charles score will tell the risk and also tell you whether this patient needs anticoagulant or not. So this score is for preventing the stroke. This is not to assess the cardiovascular risk. Cardiovascular risk is the patient will develop any kind of cardiovascular problem in the next 5 years. It can be a stroke, it can be a heart attack, it can be an MI, it can be any peripheral arterial disease, it can be anything. Okay, and that is done with cardiovascular risk assessment tool. So the whole term for that is Australian CVD risk calculator. So if you open this link, it will show you that considering the age of the patient, the diabetes status, smoking status, gender, ethnicity, the HDL cholesterol ratio, blood pressure, everything, like they have space over there to fill the form. And after that, it will tell that how much chance of is there for the patient to develop any cardiovascular disease in the next 5 years. And if they don't take action, like they don't do exercise, don't take healthy diet, don't control their blood pressure or things like that, then this is definitely the chance. Otherwise, if the patient start having some preventative activity, then this risk can be reduced. So this is that risk calculator that they are asking for, and it is written in the Red Book. All people age 45 to 79, you can calculate the CVD risk. Okay, every 5 years, unless risk factors worsen. So ideally, it is every 5 years you have to calculate this risk. Okay. So this is the link for that red book. Sorry, this is the link for the risk calculator that is mentioned in the red book. You can just have a look. You don't need to remember it, just for making concepts. Next question is 2-year-old identifies now as Aboriginal. What vaccine to give? Hepatitis A, meningococcal ACWY, flu B, I think it is Haemophilus influenza they want to write, rotavirus or another viral one. So they regarding the vaccination, I told you that we will be following Australian immunization handbook, and they tell you for Aboriginals you have hepatitis A, that is additional vaccination in a 2-year-old child. Haemophilus influenza B, HIB, that is given at 2, 4, and 6 months, and at 18 months. But that is given to all children, right? Regardless of whether they are Aboriginal or not. So if this child now tells that he's Aboriginal, the parents now tell, he will still be having had this at 2, 4, and 6 months. He would already be having this. So there is no need, like this is not an additional vaccination for Aboriginals. Similarly, meningococcal vaccine ACWY, this is also given to all the children regardless of their ethnicity. Similarly, rotavirus is also given to all the children. And the only vaccination that hepatitis A, this is not given to Australians, it is only given to the Aboriginal and Torres Strait Islander ones. Okay, so from these options, hepatitis A is the one which we have to give since the parents now told that they are Aboriginal. Okay, so this is due to the increased risk of hepatitis A in this population. These children should receive first dose at 18 months. So ideally it is given at 18 months, although this child is 2 years, so you can just give him the catch-up vaccination. And then the second dose would be around 4 years of age for a booster. Okay. So this is funded through the government for all the Aboriginal and TSI children, hepatitis A vaccine, and it is not given to the other the other Australians, okay, the non-Aboriginals. This is the National Immunization Program schedule for the children. So you can see here, meningococcal ACWY is for everyone. The ones written in purple are for everyone. The ones in brown are for Aboriginals. They are the extra ones. Okay, so Aboriginal will also get this purple one, but the brown ones are the additional, which will the Aboriginals will get. The non-Aboriginals will not get these brown vaccines or brown colored. Okay, so ACWI, you can see that everyone is getting, whether they are Aboriginal or not, around at 12 months. Similarly, Haemophilus influenza, once at 2 months, then 4 months, then 6 months, and then the booster at 18 months. Everyone is getting it regardless of their ethnicity. Similarly, rotavirus, everyone is getting. The additional vaccine the Aboriginals are getting is this hepatitis A at 18 months, and then a booster at 4 years, the second dose at 4 years. Similarly, meningococcal B vaccine. So you can see there is a vaccine ACWY and there is a vaccine B. This meningococcal B vaccine is not given to non-Aboriginal. It is only for the Aboriginal ones, okay, because they are more susceptible to having this meningococcal infection. All right, so they will be, as the child reaches, so they are having meningococcal B at 2, 4, and 6 months, then booster at 12 months, and then this is the similar to Haemophilus influenza. Okay, so you can also see, you can remember that Haemophilus influenza is at 2, 4, and 6 months, and then 18 months. Similar is the case with that other one. Okay, the meningococcal B, instead of 18 months, it is at 12 months. And influenza vaccination, this is given after 6 months to less than 5 years annually. Okay, so this is given annually, and this is given to all children. But after 5 years, usually it becomes, you can say, to Aboriginal only after 5 years. So after 5 years, if the child is Aboriginal, you will give him annually. Like you will continue giving on 5 year onwards to Aboriginal as well. Okay, so this is the National Immunization Program schedule, and you need to remember all these vaccinations. So for this Aboriginal child, hepatitis A vaccination, the age is appropriate for this one right now. So next question is patient with history of left leg pain while walking 200 meters. He came now with acute pain in the left leg. Sorry, what is Aboriginal? Aboriginal is like the ethnicity that is here in Australia. Usually, like they say that they are their, what should I say? The most ancient Australians, or you can say the very previous people who used to live in Australia before the Europeans came here. They are called as Aboriginals. Okay. Yes, they are also called as indigenous people, and they since they live in close communities, they live close together, so they are susceptible to many other different sort of infections like streptococcus infections, this hepatitis A, you can say meningococcus, pneumococcus, different, and TB, very such infections which are spread due to the closely living population. They are very susceptible to this aberration. So that is why a separate importance is given to these. There are separate guidelines for these people. Okay. The financial differences are there as well. They smoke a lot, like the smoking ratio is more in them, drinking ratio is more in them. So that is why they have some separate guidelines. And you will see that the red book, they have like a separate red book as well. So as you will do the questions, you will come to know the uh, guidelines for Aboriginals as well. Okay. This is the question, doctor. 2-year-old identifies now as Aboriginal. So the parents might have told now that they are Aboriginal. Okay, so now what is the catch-up vaccination? So this child was already having ACWY in Haemophilus influenza type B rotavirus. The only thing that was not given to him before was hepatitis A. So now we will give it to him. So the next question, patient with history of left leg pain when walking 200 meters came now with acute pain in the left leg. On examination, leg is cold, it's pale, left leg pulses, femoral is intact, but popliteal and distal are not intact. Right leg, femoral and popliteal are intact. Distal pulse is not intact. Which of the following is the most appropriate management? CT angio, above knee amputation, catheter directed thrombolysis, or heparin and observe? Hmm. Yes, so important thing here that you need to differentiate, you need to know that there is like a difference between peripheral arterial disease and this acute limb ischemia, right? So you know acute limb ischemia, there are 5 P's, right? Pain, pallor, perishingly cold, paralysis, paresthesias, right? If you have 5 P's, this patient is at risk of having uh, a loss of limb. So that is why acute limb ischemia is an emergency. Although this patient had a history of intermittent claudication, but this thing he had developed right now, this is not related to his peripheral arterial disease. This is a separate entity. Acute limb ischemia is a totally separate entity, and the cause can be anything. It can be a thrombosis in any artery, it can be any embolus that has stuck in the lower limb, okay, or any popliteal aneurysm. It can also be the cause. So that is why it is considered separate. This screenshot is from RACGP and it says that acute limb ischemia, it is separate. It is not included in the classification of PAD, separate pathological process to atherosclerotic, especially if because underlying risk factors are different. Okay, patients who have underlying atrial fibrillation, they may develop this acute limb ischemia. Okay. So anything which is increasing the risk of thrombosis or embolism, that can be the underlying cause. So they have 5 P's like pain, pallor, paresthesias, pulselessness, and perishingly cold, okay, and paralysis. So now the important thing you need to know that there are some stages of acute limb ischemia uh, that would tell us that if we can save the limb or not. Okay. There are two categories, three categories. One is viable, like at this stage, the limb is pretty much, you can say it is not threatened and we can save the lower limb. The limb is threatened. Okay, so now the limb is at some threat of developing gangrene, or you can say losing. The patient is at risk of losing his limb. And third is irreversible, in which their irreversible damage has been done, and now the only solution is the amputation. Okay, how will we differentiate? The important point you can see here, sensory loss, which is the paresthesias, the 1P, and muscle weakness, which is you can also say paralysis. So you can see from the 5Ps, paresthesias and paralysis are the most important ones, which will help us differentiate whether the limb is viable, threatened, or irreversible damage has been done. In viable limb, you can see that there is no sensory loss, no muscle weakness. And this is the case over here. Okay, you can see that the limb is pallor is there, cold, perishingly cold, and pallor is there. Pulses are lost, but there is no mention of paresthesias or paralysis. Okay, so it means that this is a viable limb, it can be saved. Okay, if and also regarding the Doppler, you can see that arterial and venous pulses are audible in Doppler ultrasound. Okay, regarding the threatened, if it is marginally or at borderline threatened, there is just the paresthesias are just at the toes, and there is no paralysis. Okay, but in immediately threatened, the paresthesias are now in the foot. There is rest pain, but and also there is paralysis, mild to moderate. But in irreversible, there is profound paresthesias and profound paralysis. Okay, so now this limb is not salvageable. This is irreversible damage has been done, and you will do amputation in this case. Okay, so you need to know that in what level, what kind of sensations are there, paralysis are there or not. And also in threatened and irreversible, you would have inaudible Doppler sounds. Okay, so let's move to the treatment. You have to keep in mind these three things. Okay, this is again from the Emergency Care Institute guidelines. Like I mentioned, that we will be having a reference from this website. So this is this again the same thing mentioned. Okay, the viable limb, marginally threatened, immediately threatened, and irreversible. And they have written the same things that I have mentioned in the previous table. So then diagnosis would be duplex ultrasound, CT angio, and angiography in OT. Duplex ultrasound will help you tell one, the flow in the arteries or the veins, and also it will tell you how much obstruction is there, what is the degree of obstruction, okay, because it is duplex ultrasound. CT angio can also be done, and angiography in OT can be done. Then the management after initial resuscitation, you can see that heparin is coming in the initial resuscitation. Okay, so after initial resuscitation, that you give the fluids, you give painkillers, you give heparin. The definitive treatment is dissolving that clot. Okay, so you can see here it would depend upon the viability of the limb. The categories that we have mentioned here, the definitive treatment will depend upon this. So that is why it is important to remember all of this. So if it is a viable limb, it can be managed with catheter-directed thrombolysis. If it is a threatened limb, or if it is irreversible, then we can do surgery, and surgical options can include either embolectomy or it can include a bypass surgery. And if it is a non-viable limb or irreversible changes have happened, then the only treatment left is amputation because the limb is dead. Okay, this is from the Australian, from the NIH guidelines, but you can see here they have written The CT requires only 20 to 30 minutes for completion and can be performed while preparing the operating room. So you don't have to think that this will waste the patient's time. Okay, let me tell you this one. So you can see here limb ischemia happened and we have given heparin in the resuscitation. After that, we can see that the limb is salvageable or viable. We are doing the imaging. You can do the CT angio here. If it is borderline or marginally threatened, the second category that we mentioned, again, we are doing the imaging. If it is immediate type of threatened limb, then we can do imaging, but we are doing the revascularization, which is the endovascular treatment, okay, or surgery or hybrid therapy can be done. But if it is irreversible, amputation is the treatment of choice. Okay, so this is from the Life in the Fast Lane. Life in the Fast Lane is also one of the Australian guidelines, so you can have reference from that as well. So you can see here, if is so now they tell severity classifications. Okay, incomplete, complete, and irreversible. It is the same as the previous one. Don't worry. Irreversible, limb not viable. Complete, limb is threatened. So that is like either marginal threatened or immediate threatened. And incomplete is the one in which the limb was viable. It was not threatened. Okay, so for incomplete, you can see that if ischemia is incomplete, the patient should have pre-operative imaging. Okay, since simple embolectomy or thrombectomy is unlikely to be successful, thrombolysis may be an option. Surgeon requires a roadmap. So the surgeon requires a roadmap. He needs to know where is the thrombosis, where exactly, how much is the size, what is the degree of obstruction and everything, and how many, whether there are any collaterals due to any underlying peripheral arterial disease or anything. He needs to have a complete detailed picture. Okay, so that is why preoperative imaging is important in case of viable limb. In this case, okay, in category 1, patient is having imaging. He has time for imaging. Okay, so this is our case here. The patient has no paresthesias, no paralysis. He has time, so we are going with CT angio over here. Okay, amputation, this is not a irreversible change over here right now. Amputation is not required. Catheter directed thrombolysis, yes, we can do afterwards, but that would be required afterwards if the limb is immediately threatened. Okay, and heparin and observe, they are asking about the most appropriate treatment, not the initial one. If it was initial, we would go with heparin. But again, in this option, observing is not the right treatment. Okay, you need to, even after you have given the heparin, you need to have some definitive treatment because this is acute limb ischemia and this is an emergency. Patient just has 4 to 6 hours. After that, he will lose his limb. So observing is not the thing here. This option is completely wrong because of this observe word. Okay, so 3 options are left. Amputation, I've also told this is not an irreversible damage right now. We are left with catheter directed thrombolysis and CT angio. Since this is incomplete ischemia, that is why we will do CT angio. We have time right now. Okay. When to do duplex ultrasound? Duplex ultrasound can be done at bedside as well. If, for example, you don't have CT angio available, you can do the duplex ultrasound. It is also very good at telling all the anatomy of the lower limb. And if, for example, the patient has any renal failure, he cannot have any dye. So that is why you can do the duplex ultrasound there as well. So if the ischemia is complete, like complete means the limb is threatened. So then we are taking directly to the operating theater. And because angiography, CT angio will delay the diagnosis, will delay, and thrombolysis is not an option. There is no collateral flow as well. So that is why if the limb is threatened, we are going to take for operation theater. And then intraoperative angiography can be done, or depending upon the surgeon's decision. If duplex was mentioned, would we select it? They're asking about the most appropriate treatment, doctor, so most appropriate management. So if they're asking about most appropriate, then you should go with CT angio. So there is like a similar, so answer over here is CT angio. Okay. There's like a similar question. 40-year-old healthy woman presents to the emergency room with a 4-hour history of sudden onset, right lower limb pain. Her examination reveals intact femoral pulse but absent distal pulses, diminished sensory exam with an altered motor exam or paralysis. Her labs are normal, blood pressure 110/70, heart rate 95, respiratory rate 18, temperature 36.6, and oxygen is 98. ECG shows atrial fibrillation. Which one of the following is the most appropriate management? Femoral embolectomy, above knee amputation, catheter directed thrombolysis, or heparinization and observation? So, what would be the answer here in this case? Yes, so again, this is the case of acute limb ischemia. Why? Because the patient has underlying atrial fibrillation. Most likely, there is some embolus that is stuck in the lower limb. Okay, so and also there is diminished sensations and there is paralysis. So, this is like, where's that table? So, this is like immediately threatened limb. Okay. So that is why we need to save it and we need to take the patient to the operating theater as soon as possible. And since it's like an embolus, so we will be doing femoral embolectomy. Amputation right now would not be there, would not is not accurate because this is not an irreversible damage right now. We can save the limb right now. And again, catheter directed thrombolysis is for a thrombosis, not an embolus. Heparinization and observation, again, just because of this observation word, this is not an accurate answer. And also, they are asking about the most appropriate management again, so this wouldn't be the most appropriate one. Heparin is initial one, but not the most appropriate. So, surgical intervention for the two, rather for 2B. 2B, this is the immediately threatened limb that I've just shown in the table. So for this, if the cause is embolic, so in our case, patient has underlying atrial fibrillation. So most likely it is some embolus that is stuck in the limb. So the cause is embolus. So we can do the embolectomy. Okay. Um, if it is not possible embolectomy, then we can do thrombolysis. Okay, or we can do the bypass surgery. If there is a thrombotic cause, then we can do intra-arterial or catheter-directed thrombolysis, okay, or angioplasty or bypass surgery. So in our case, it is embolus, so femoral embolectomy is the best answer here. Clear, guys? This is again a very important topic for AMC Part 1. So the references I have attached to all of these articles over here. From this, the first one is the RSCGP article, the Australian guideline. The second one is also Australian. This is a Life in the Fast Lane Australian guideline. This is the STAT Pulse, the NIH, and this is the Teach Me Surgery. So first three are Australian guidelines, okay? So there's like a minute difference between embolectomy and thrombolysis. Embolectomy, you can see that they are inserting a catheter using a guide wire, but that is for the embolus specifically, okay? But for a thrombus, you are using a medication, you can say, intra-arterial, okay, to thrombolyze. Any type of heparin you can give, doctor. The low molecular weight ones are preferable. Pregnant with female with fundal height 32 and she was 28 weeks pregnant, that what can be the cause? Been regular visits, had scans estimated from 10 week scan, polyhydramnios or wrong dates. So there are a lot of causes of why there can be an increased fundal height. Although this patient is 28 weeks pregnant, but her height is 32, plus minus 2 is acceptable. For example, if she's 28 weeks pregnant, if the fundal height was 30 centimeter, it would be acceptable. But 32 centimeter is like four difference of 4, so this is very much high. So most likely it is some cause that is causing this increased fundal height. So the statement says that she has had regular visits, she has had her scans. So if there were regular visits and if the scans were there, estimated from 10 weeks scan, especially, so this means that she has had her dating scan. Okay, so the dates cannot be wrong. The chance of dates being wrong is very less likely. So most likely it is polyhydramnios, because sometimes like she had her regular visits and scans. So if it was like any twin pregnancy, it would have been diagnosed earlier. If it was any fibroids, it would have been diagnosed earlier. But polyhydramnios, it can develop at later stages as well. So even if her previous scans were normal, she can still develop polyhydramnios at any later stage. Okay, so from these two options, polyhydramnios is the right answer. uh, s- Wrong dates has been ruled out because of a correct dating scan. So next question is, 26-year-old man presented with right inguinal pain for 2 days after weekend trekking. On examination, there is tender swelling over the inguinal ligament. The lump is non-reducible and does not show expansile cuff impulse. He doesn't have any lower limb wounds. So what is the diagnosis? Inguinal lymphadenitis, subcutaneous abscess, direct inguinal hernia, femoral hernia, or indirect inguinal hernia. Yes, so this is a 26-year-old man, young man, and he had gone to trekking. So there is like a possible chance of any insect bites or any unnoticed minor trauma. Okay, and then there is pain and swelling, tenderness over the inguinal ligament. All right. So regarding the subcutaneous abscess, if it was subcutaneous abscess, the swelling would be more fluctuant. There should be a mention of any fluctuancy, like any suspicion of fluid. Um, and abscess comes with systemic features like any fever, right? So nothing like that is mentioned. So we can rule out subcutaneous abscess. Femoral hernia, more common in females. Okay, we can rule out. Um, Direct inguinal, indirect inguinal hernia, and inguinal lymphadenitis. Okay, so direct inguinal hernia is usually reducible. Um, it is less common in young men, you can say. Although there is a risk of strangulation, you can say that what if it is strangulated hernia? But the important point here is that it lies over the inguinal ligament. Okay, the word over the inguinal ligament. You know that hernia, indirect one, it can proceed into the scrotum. All right, and direct inguinal hernia, it is above and medial to the pubic tubercle, right? And femoral hernia is below and lateral to the pubic tubercle. So it is not something which is present over the inguinal ligament. This is the location of inguinal lymph nodes. Okay, so that is why it is going more with inguinal lymphadenitis, because it is a tender swelling, it is present over the inguinal ligament, and there is a history of trekking. So maybe there is an unnoticed insect bite. Okay, and the if it was any if you see this non-reducible swelling does not show expansile cuff impulse, If you say that this is any strangulated inguinal hernia, then there must be any signs of obstruction as well, right? Any skin changes over that area, any vomiting, constipation, and decreased or hyper bowel sounds or absent bowel sounds, anything mentioned regarding the gut as well. Nothing like that is mentioned, so we can safely rule out direct and indirect inguinal hernia as well. Okay, the most likely diagnosis here is inguinal lymphadenitis because it is tender, it is present over the inguinal ligament. Okay, and there is a trekking history. So you can see here, um, here this is like the pubic tubercle almost here, goes to the anterior suprailiac spine, and this is the location of the inguinal lymph nodes. Okay, this is again the inguinal lymphadenopathy, and you can see that it is present over the inguinal ligament. Again, this is the inguinal lymph nodes, enlarged, right, slightly tender lymph nodes. Okay, and this is the position of the hernia. Inguinal hernia, the direct one, above and medial to the pubic tubercle, and femoral hernia is below to the pubic tubercle. Okay, below and lateral. So most likely diagnosis here is inguinal lymphadenitis due to location and tenderness. If it was strangulated, we would have some signs of obstruction, and if it was there, then strangulated hernia would move to the top of the list. Okay. And from the direct and indirect, the direct one has a more chance of strangulation. So next question is female patient 54 years diagnosed as chronic heart failure for 3 years, symptoms controlled on captopril furosemide, presented to OPD complaining of intermittent dry cough for 3 months, no shortness of breath, no orthopnea, vitally stable, cardiac and chest exam unremarkable, no lower limb edema, no signs of any heart failure. Chest X-ray shows it is clear with no significant signs. What is the appropriate next step? Increase furosemide, add inhaled beta agonist, do pulmonary function test, or stop furosemide. So here we can see that heart failure is controlled. There is no decompensation, right? Chest X-ray is clear. There is no edema in the body, no orthopnea. So increasing furosemide does not make sense. She's quite stable. There is no decompensation, right? Again, stopping furosemide also does not make that of a sense because it does not address the dry cough. It's not that a side effect of furosemide. The dry cough is a side effect of this medication, the captopril. Okay, we need to stop this medication. ACE inhibitor is a very known side effect of dry cough is a very known side effect of ACE inhibitors, and we need to start this patient on any other medication like angiotensin receptor blockers. Okay, so if you have the option of changing captopril or stopping captopril, adding shift to ARBs, then that would be the best answer. But since we don't have that in option, what we can do is we can check the pulmonary function test of this patient. Okay, because this is like a dry cough for 3 months. Although if it was asthma, it would be that the patient has dry cough, wheezing, shortness of breath. Other respiratory symptoms must be there if the patient has some respiratory problem, right? So adding inhaled beta agonist right now, this doesn't seem appropriate because just intermittent dry cough does not tell you whether the patient has any asthma or any bronchoconstriction, right? So what we can do is we can check her lung function test and see if she has any asthma development. Then we can add SABAs later on. Okay, but right now we can do the pulmonary function tests. Also, one article says that the ACE inhibitors, they can increase the risk of bronchoconstriction, hence developing of asthma, or if the patient has already has asthma, it can make it worse. After discontinuation, ARBs can be initiated and this cough gets better. And other than that, you know that it is because of bradykinin, right? This dry cough. So first, the best option would be to stop the captopril, but since we don't have that, so we can go with the pulmonary function tests. All right. Add inhaled beta agonist would be at a later stage if anything abnormal comes at the pulmonary function test, or stopping captopril does not make this cough better, then we can add this. Look for option of stopping captopril or changing to ARBs. Right now we can go with pulmonary function tests. Okay. 10 years old with type 1 diabetes mellitus claims daily sugar reading 5 to 7 or 8. HbA1c is 15. Did not bring her machine today. What could be the reason for the difference in reading? Expired glucose strip or patient giving false readings? Yes, so this is the case of type 1 diabetes, okay? And this is the case of an adolescent, like a 10-year-old. It is a very high chance that she is faking this daily sugar reading, because obviously you need to check it with it is like an invasive thing, right? You need to prick the child 3 times a day, 4 times a day. There is no reliable non-invasive method for checking blood sugars right now for diabetic patients. We need to have a strict monitoring, so that is why children usually they do fake it. They can write fake notes in their diary, fake readings. And once maybe this child does not know that her blood sugars can also be checked with HbA1c, right? So when we checked the HbA1c, it was 15, very high. So there is a high chance that these readings are fake. And also, she did not bring her machine today because she knows that in the machine you can see the previous history, right? So this is most likely a patient is giving the false readings. If it was expired glucose strips, yes, expired glucose strips can give you false readings, or any normal blood sugar. But if the strips are expired, they will not always give you normal range. Sometimes they can give very high, sometimes very low, sometimes they can show error. So it would be like a very variable readings if the glucose strips are expired. And also, in case of children, this one is more common, that children fake their readings. This is from the type 1 diabetes handbook given in the RCH. So they say that after years of blood glucose monitoring, they lose the motivation and do less or no monitoring. And there may be a tendency to write down false readings in the record book so as to satisfy the parents and the diabetes team. The only goal for children, obviously, is that they should stop taking the insulin, because who likes needles, right? So that is why this is more common as compared to the expired strips. And this is showing the HbA1c and the estimated average blood glucose. So if the HbA1c is 10%, you can see that the average blood glucose would be around 13.4. So our patient has 15% HbA1c, extremely high. So there is no chance that her blood sugar levels, the random ones, would have been normal all the way. All right. So most likely this patient is giving false readings. So, second last question, I think this is 24-year-old patient presented with itchy rash over the forehead. She recently adopted a stray cat and she's claiming she developed rash after that. What is the possible diagnosis? Cat scratch disease, tinea fasciae, allergic reaction, or leishmaniasis? So, this rash is just localized to the forehead. It can be an allergic reaction. Allergic reaction would be, first of all, it presents in a very different form. It can be in the form of hives. It can be in the form of any angioedema, anaphylaxis. And usually allergic reaction, as if it is not a contact dermatitis, that allergic reaction is in the whole body. Okay, for example, if it is to a drug or anything, it is usually throughout the like very widespread rash. If it is a contact dermatitis, usually it is on the area where the contact happened. But this is like just over the forehead, and no mention of any contact is present that would show any allergic reaction. So we can rule this out. Similarly, leishmaniasis, it is not very common in Australia. Okay. And there is, you can say that uh, it is transmitted with a fly. Okay, and it causes many cutaneous ulcers as well. It does not present as just like a itchy rash. Okay, and cat scratch disease, yes, it can be there. Like there is a history of stray cat, and she said that she developed rash after that. But cat scratch disease does not present like the itchy rash over forehead. Usually, if there is like a cat scratch and over the scratch area, you develop some rash or any papule over there, which is like red in color. After that, it ruptures and heals. But the regional lymph nodes, they become swollen as well. For example, if there is like a cat scratch on the forearm, uh, a nodule will develop over there, a papule will develop over there, and there would be axillary lymphadenopathy. Okay, and those lymph nodes are tender. Nothing like that, any lymphadenopathy is not mentioned in this scenario. So cat scratch disease is also less likely. We are only left with tinea fasciae. This is like the fungal infection of the face. And since she has a contact with animals, so any fungal infection can also develop. Okay, and since this rash is itchy, so most likely it is any fungal infection. Okay, so this is the screenshot from the DermNet website. Okay, so I've told you that for any dermatology picture, you can refer to this website, and you can see here that they have shown the tinea fasciae. So you can see the fungal infection on the face. So they are extremely itchy, and they can develop. So this patient has developed on the forehead. Okay, this is also one of the rash of the tinea fasciae. And most common is Microscorum canis that can be acquired from the cats and dogs. Okay, and also from the farm cattle. So this is like also zoophilic fungal infection. So you can see that she had an exposure to the cat. So that is why tinea fasciae, this picture is most likely going with this one. Okay, you can see leishmaniasis. It presents with like an ulcer, extremely different picture. And also leishmaniasis is very less likely, very less prevalent in Australia. This is the allergic reaction or the urticaria. You can see the hives. They are raised patches present throughout the body, and they usually change their place. They will disappear from there and develop anywhere else in the body. Okay. And this is the primary lesion of the cat scratch disease. You can see there is like a papule where there was a cat scratch. And after this, there will be a regional lymphadenopathy. For example, if this is on the forearm, so axillary lymphadenopathy will be there, and those lymph nodes will be tender. Okay. So most likely it is tinea fasciae. And this is this website, Dr. dermnetnz.org. You have, for example, you have to search tinea fasciae. Just write in Google tinea fasciae dermnet, and you will get that link. And this is a similar question. 8-year-old boy with red itchy rash on forehead. Recently, he handled a street cat. There is no fever. On examination, everything is normal. Diagnosis: tinea fasciae, drug allergy, eczema, psoriasis, or seborrheic dermatitis. Yes, so you can see this picture usually comes, this question usually comes with a picture in exam. So that is why it is important to look at the pictures and to see, and you should know how different diseases look like. Okay, again, eczema, you know, it is most common presentation is on the flexure areas like on the elbows or the back of the knees. We have an itchy rash on the just on the forehead. Eczema is less likely here. Similarly, psoriasis, you know, psoriasis is on elbows and usually it is like silvery, scaly appearance. It is not like an itchy rash just on the forehead. Okay. Again, and also there is like a animal handling history. So psoriasis is also less likely. Seborrheic dermatitis, in short or in simpler terms, it is just the dandruff. Okay, so it is present where the hair follicles are present. So it is also less likely. You can see a lot of flakes on this rash. And we are left with drug allergy and tinea faciae. Drug allergy, like I've explained, allergy is usually widespread, and if it is a drug allergy, it is a widespread reaction on the whole body. It can have many appearances. It can be in the form of urticaria. It can be a very maculopapular or morbilliform. Morbilliform, why very small red patches on the skin. Okay, but it is very widespread. And tinea faciae, we are left with this option. Again, I've explained it can be transmitted through the street cats. Okay, there is no fever, everything is normal. Why not eczema? Kindly repeat. Eczema, because eczema is usually on the flexural surfaces. Okay, flexures means that on the antecubital fossa or on the popliteal fossa, usually eczema is present over there. And eczema has a different presentation. It is not like an itchy rash just on the forehead. Okay, and in order to diagnose eczema, they will give you some other history of allergy as well, like any family history of asthma, family history of hay fever, any personal history of hay fever or asthma, allergic rhinitis, any history of atopy would be there, and then you can diagnose the eczema. Okay, they will give you some clue regarding that. All right, so this is tinea faciae most likely. This is the picture of the other options that we have. You can see seborrheic dermatitis. You can see the flakes here on the eyebrows and also on the face. Okay, so they present like a very flaky dandruff sort of appearance. Again, this is seborrheic dermatitis. You can see the flakes on the hair follicles near to that. This is psoriasis, very distinct lesion. You cannot miss this diagnosis. This is psoriasis, and this is eczema. Discoid pattern of eczema, hand eczema. So you can see, all right. So this patient would have some history of allergy or any atopy. And this is again hand eczema. It is a blistery sort of thing. You can see over here. You can see very small patches or dots. So this is also a different picture of eczema. So this, you can have a look at this website for different dermatology cases. So the answer here most likely is tinea faciae. Okay. All right. So I've tried to answer the questions, and this is how we will be doing the MCQs. The random topics will be touched, and you will see that as we discuss these topics, many different topics will be covered. And if you will attend all these classes, you will go through these topics again and again. Things will be reinforced. All right. It will seem a little bit overwhelming right now, but the only way you will clear this exam is when you will go through it again and again. Okay. All right, everyone. Have a good night.